Coming to you live.
Good afternoon, everyone. This is Andy Reese. It is 12:05. I'm assuming I'm off mute. Oh, he's signing, so that means you can hear me. I'll just start with a brief overview of where things stand in terms of COVID-19 for people supported by DDA in the district currently. We have had 212 people who have tested positive for COVID-19 and unfortunately have lost 28 people. There are currently 2 people hospitalized. We have 109 people who have not required any inpatient treatment for COVID-19. And there are 73 people who received inpatient care and have since been discharged from the hospital. Of the 212 people who've been diagnosed to date, 89 of those were in supported living placements, 77 were in intermediate care facilities, 27 were in residential habilitation placements, 14 in natural homes, 3 in host homes, and 2 in nursing homes. There have been 243 provider staff who have tested positive for COVID-19, and that includes 8 people who work at more than one provider agency. And we unfortunately have had 6 provider staff who have passed away from COVID-19. So we had just a couple of questions, and maybe we'll do those questions. And then today we wanted to spend a little time talking about some of the information we gave people before about day services and retainer payments. We spoke with CMS earlier this week, so we can provide an update there. Not all that different from the information we provided last week, but it's the current, most accurate information we have. And then just some discussion of sort of where we are in terms of looking at how we're doing with implementing the assessments with people of their community participation assessment and questionnaire, as well as working with people to engage in day, what it looks like to be able to begin those day services, some discussion about what we could do in terms of employment readiness perhaps, answer some questions about that, and also look at guidance that people have been giving us feedback for. We're looking forward to phase 3, and so we're starting to think about what that guidance will look like, and I just want to walk through that. And what's really become clear, and I talked about this some last week where I said we're putting together a group to begin to have these facilitated discussions about people's rights during the pandemic. And as people commented on the phase 3 guidance, it was very clear the sort of pressure we're seeing now between sort of protection and rights, and just kind of walking through what, even though COVID-19 changes nothing about people's rights, I think that because of the potential consequences, it has become very starkly clear, sort of, you know, this pressure point between wanting to protect people versus people, you know, who live in the community and have all the same rights as the rest of us, and how do we balance those two very legitimate concerns. So we're going to be, today we'll be sending out the draft of our PowerPoint that will function as the facilitation for the discussions about this. We've asked a number of different people to help us to finalize those, and then to help us with that facilitation. And then we're also going to be forwarding we'll be finalizing within the next week or so some guidance regarding people's rights. And,
It looks like our ASL interpreter can't hear you right now. Let me hold 1 second.
so can anyone hear me? So we don't seem to have the interpreter with us right this minute, so we're going to hold on just a second to make sure that this is accessible to everyone.
Hey Matthew, can you hear me? This is Kirk Upson. Andy, can you speak please, just to see if he can hear you as well?
Matthew, are you able to hear now? Oh.
Okay.
Okay. Sorry that we cut off there for a minute, and I don't remember where I was, so perhaps we could now move on to the questions.
Okay. Good afternoon, everyone. Some service coordinators have indicated a need for a written plan for how a person supported intends to spend their economic stimulus checks. Others have not requested this information, and we're getting mixed messages about what is needed. Could you please clarify this, if this is needed, and if so, could you please direct us to the written communication transmittal regarding the need for a written plan?
So there is no written plan as a part of our, there is no written plan, but it is in our policy, our personal funds policy, that all funds have to be accounted for. And the expectation is that the person had an individual financial plan developed at their ISP, which is amended in case they hit the lottery or start working or any other funds come in. And the expectation is that all monies are accounted for with receipts for purchases that are above $50. So it's not, and I do apologize if some service coordinators have not been able to accurately communicate that, but what I know is that some work off of having meetings to plan, and some plan and then share with providers. So I will be sending an email to all service coordinators to ensure that the message is communicated consistently and effectively across the board.
So to be clear, during COVID-19, there's no change in our policy. There's no need for a stimulus check procedure. It is the same procedure that exists whenever anyone's income changes during the course of the year.
Can we provide telehealth services for employment readiness? Can we have our staff go to a residential provider's home and provide the employment readiness service in the home?
So these are two really good questions, and actually we are also thinking about, and we're going to have a meeting next year to discuss how we might be able to, so one of the challenges with employment readiness and providing telehealth employment readiness to people who are in a placement where they're receiving other services is that you cannot bill two Medicaid services at the same time. And so if people are in a home and they're required to have staffing in the home with them, then you couldn't remotely provide employment readiness because someone has to pay both staff. So that's one challenge. The other suggestion, could a provider, could an employment provider work with a residential provider to say, how about we have our staff there during the day to do employment readiness? Or even some of our residential providers who do both, rather than doing companion, could you do employment readiness? Yes. The issue being you cannot bill two services to Medicaid at the same time. So if you were to switch them out in that manner, that could work. The other thing we're considering, and we'll be talking about this early next week, so I'm hoping that by next Friday we'll have an update for everyone, is the possibility that we could authorize job readiness through RSA, and that way the providers could provide it remotely and be paid by RSA, so we wouldn't be billing Medicaid for two services at the same time. As a practice up until now, we've only used RSA job readiness for people who were sort of closer to ready, and it's been a 2-week service. So we're going to need to look at those policies to make sure that under our existing policies we could do it and just keep reauthorizing more than just the 2 weeks. But, you know, historically it's been if someone needed sort of extensive employment readiness, they would get it through the waiver. If they were closer to being job ready, then they would get it from RSA. But I think that we might be able to look at doing this through RSA so that people could get that service while they're at home.
Is it accurate to say that the retainer ends July 15th with the stipulation of length of billing restricted to 18 weeks?
Not exactly. What we learned from CMS this week and from the guidance that we sent out to all providers a week ago that we had gotten from CMS just last week is that retainer payments can be paid for 30 consecutive days of service, and that we can only have 3 periods of 30 days. So that works out to 90 days of service, which is about 18 weeks. Those retainer payments, if they had started on March 11th, would have ended 18 weeks, gets you through this week. But the retainer payment as part of our Appendix K is in place until March 10th, 2021. And so you could do the retainer payments in the future. I do want to, so because of this change with retainer payments, it delayed CMS approving our amended Appendix K. So I'll answer my question, the question I expect about what do we know about the Appendix K. We don't yet in terms of particularly companion 1 to 2. We submitted that. We got comments from CMS, but not about that, so we expect it to be approved. But we have to submit some final changes. CMS, after we met with them on Wednesday, had to go back and get some answers from up the chain. They expected to be back to us with those answers by early next week. and then we will revise our final amendment to our Appendix K and get it into CMS and hope that it will be approved quickly. There are some provisions in the in this new guidance that speaks to providers having to retain staff, and the issue there is the importance of ensuring that, that the service is maintained. Now, I do get that by limiting the number of periods that it's authorized, it makes maintaining the service until people can really fully re-engage in day much more challenging. But the response from CMS on that was that there are other sources of federal funding that are available and that those really need to be relied upon. One of those is the CARES Act provider support funds that people can apply directly to HHS for those funds. It's not CMS. And we have sent out guidance, I think 3 times now, so that providers can get that information and can submit their applications. Those are due by July the 20th. And providers are eligible, it's, I believe, 2% of their gross payments from the prior calendar year. And so providers had to submit what their billing had been from the prior year, and then had to submit applications by July 20th, and they're eligible to get those payments from HHS. Providers are also eligible to get PPE. One of the PPP, sorry. One of the things that providers are going to have to provide an attestation when for the retainer payments is that they're not getting paid more than once for the same thing. And so to the extent that providers, for example, use PPP to maintain their direct care staff because our retainer payment did not pay for that, that's fine. But it's going to be important in terms of accounting for any funds received, that what those funds were spent on is accounted for, because at the end of all of this, there may well be audits, which we'll check to make sure that there were not, that there wasn't sort of, double dipping in terms of using various pots of federal funds to pay for the same thing. I don't see that being as much of a challenge as figuring out what all the various pots are and using them to stretch out the viability of your business as we begin to re-engage people in day services.
And this is in regards to the retainer ending July 15th. For something so drastic as this, why are day providers giving less than a week's notice?
We gave the notice that we got. I mean, unfortunately, we got notice from CMS. CMS reached out to us and scheduled a call with us about it because they recognized that this was short notice. We forwarded the guidance that they sent us. And so, unfortunately, we shared the information pretty much as we were receiving it.
Okay. And some comments in the chat box. With regards to the stimulus checks, it's important to be mindful that with planning, you want to make sure that the person maintains their eligibility for Medicaid. Also, some people may have received their stimulus check and did not communicate it to the provider. That was one comment.
So they may have received their stimulus check directly, I'm assuming, because the process we have in place is for when we are the rep payee. Mm-hmm. And so it's going to be important in those cases just to talk with the person, to make sure that you're accounting for how they've spent it.
Another comment, we have to consider workers' compensation liability when a day program staff works in a residential site.
I mean, those seem to me to be issues that would be resolved between the programs. I'm not sure I see that, but, you know, it's your business, so you can make those determinations. Our service coordinators come out to your sites pre-COVID all the time. And workers' compensation doesn't, I mean, they're covered by workers' comp by us. If they became injured at your location, they'd be covered by our workers' comp, is what I expect. So I'm not sure how that would be implicated.
Yeah. Here's a comment. I'm not sure if that's a question. Some service coordinators have started, I believe this is the CPAC process, excluding all team members, completing and committing, imposing that persons choose to not return to day programs.
Okay, my telephone number is 202-730-1618. For individual concerns, I would like to be made aware specifically of who that is, because that is not the process that we train service coordinators to operate under.
And people can see there's the process as well as the CPAC itself, and the PowerPoint from the training all are on our website. We may want to remind our own staff of that.
I don't even understand the question, because why, let me see. All right, another question, let me see if I can understand exactly what they're asking. Why is the stimulus check payment has been added to the DDSPA account when the check is deposited into their community account, which is creating a lot of confusion?
Yeah, this is Jared. I'll have to speak to our colleagues over at the Chief Financial Officer's area. I'm not aware of that. I'm sorry if there is confusion, but I'll have to look into that. Yeah.
Because our understanding is that those checks are not being handled any differently from any other, like if someone got a lump sum payment from Social Security, it's essentially exactly the same thing.
Correct. So and there's an explanation for all of those payments. So you should know that this is for the stimulus payment, so that you are able to differentiate that. But I will follow up on that.
Some providers are committing, or I think completing CPAC and excluding day service providers, which appear to be contrary to what was conveyed during the CPAC training.
Again, my number is 202-730-1618. That absolutely should not be happening. Well, so the process includes so let me be clear. There has to be a meeting of all parties, but the CPAC itself is not the determining factor. It is just a component of the process. So, but again, just
so the CPAC is the assessment that is done and is committed, and once it is committed, the service coordinator schedules an IDT meeting so that it can be discussed and services planned. And it is that meeting that the day providers are invited to. The people who complete the Community Participation Assessment and Questionnaire, CPAC, are the folks in the residential placement, the provider completes it, correct?
Well, anyone involved with the person can complete it who knows the person. So we have people who live at home, we have people who live in residential providers, and we have people who have just their family and the day provider. So it matters that it's done appropriately for the person, but it is the precursor to a meeting of all parties to discuss the assessment.
Who is supposed to get the CPAC, I guess that's notification when it is completed? We have received several notifications for persons we do not serve.
Again, my number is 202-730-1618. I would love to, know who they are so that if it's a glitch within our system, that we can fix it. Can you type my number?
And let me just say, Beam had given us a number of these community participation and assessment questionnaires that have been committed so far. It's a process that we're just starting. We're all working together, so it's helpful to hear where things need to be tightened up. But it's essential, as there are questions, to raise them preferably first to the service coordinator.
It's right.
Oh,
1618.
okay.
You thought you got it wrong.
Yeah, I got it wrong. Okay, so I typed in the wrong number for, Deputy Winslow. It's 202-730-1618. 1618. Are there any other questions?
So while people are waiting with any questions, maybe it would be helpful for me to walk through. One thing I do want to just kind of remind people, I've talked about this before, but we do have the group of people who've been working together on the issues related to day services. There is a group that is developing a guide called Best Practices for Day, and that should be available soon. In addition to that, we also, DC Health is developing guidance on all adult day programs in the district, and we hope that that will be published soon. They've drafted it and it's going through the review process currently, and we hope that that'll be will be available soon. It'll really be essential that we have the DC Health and the DDS guidance regarding day in order to have these meetings with people. Just as a reminder, in our Phase 2 reopening guidance, we did give the general sort of parameters of day services. I mean, day services can reopen. It's quite limited in that you cannot have more than 10 people in a room, but you also can't have more than 5 people per 1,000 square feet. That's based on other guidance from the Reopen DC guidance, and it was regarding personal care locations, gyms, those kinds of places. For the Phase 3, we don't have anything specific about square footage in our guidance, only because we expect that the DC Health guidance is going to address that issue. We began drafting our Phase 3 guidance, so that our hope is that our Phase 3 guidance will be available as we get to Phase 3. People should take advantage of all of the information that is out there. If you go to coronavirus.dc.gov under data, you can see the metrics that are required for us to move to phase 3. And you can sort of track what our progress is so that you can see how soon we may be there. It was interesting, in drafting the guidance, we've asked for input from various people, and I just want to walk through some of the kinds of, some of the thoughts people had and questions. In part, there were many questions about sort of higher risk. We include information in our guidance about people who are at higher risk for severe illness from COVID-19. I think it's more accurately people are at higher risk for transmission of and severe illness from COVID-19. And what's very important, and it was a reminder as we were drafting this for phase 3, is to always, we have a link here to the CDC, the Centers for Disease Control and Prevention website. And when you read the guidance, if you read it electronically, you can always click back there to see. The CDC does, in fact, include in its guidance that there is a higher risk of transmission and severe outcomes for people who live in long-term care placements like an ICF or a rehab. And that's the reason we've included that as high risk, as higher risk. There's been some changes in their guidance, however, so we'll be updating our phase 3 guidance, but as I say, it's important that people keep looking because as they learn, they update the information that they provide to us so that they no longer have this hard line at age 65, but just say, as you get older, the risk of severe illness from COVID-19 increases. They've also modified their statement. Previously, they identified severe obesity or morbid obesity, which is a body mass index above 40, as a high-risk group. In looking at the data, they are now saying that obesity with a body mass index of 30 or greater is a high-risk category. They've also looked at some of the other conditions. They've clarified that type 1 diabetes is higher risk. Type 2 diabetes is a higher risk, which is the acquired diabetes, as opposed to type 1 diabetes. So it is very important, as I say, to check back in with that guidance, to look at coronavirus.dc.gov and also to look at the CDC guidance. We included in our guidance a reference to the fact that Mayor's Order 2020-063 remains in place. Included in that order are all the requirements regarding screening of employees, screening of visitors. Just to clarify for people, that means anybody that comes in who doesn't live there. And so that would include, in phase 3, in a very limited way, our service coordination, quality resource, and investigation staff may do a face-to-face visit if it is necessary and with the approval of the respective deputy director. And if they do, they would be subject to the same screening as anyone else who visited a placement. The other thing that really became clear in putting this guidance together and hearing from people about the guidance was how important it is that we have clear guidance for people regarding their rights during COVID-19. Not just for the people we support, but, you know, for our staff, for provider staff, because while it's kind of the same as this question that came up regarding, you know, did we write any policy regarding stimulus checks? Well, no, because it's handled the same way as other money. But in terms of people's rights during COVID-19. First of all of us learned some things about our rights during COVID-19 when the mayor issued a stay-at-home order, and there were questions about how that would be enforced for the whole city. And then once that ended, there was the question, what does that mean for the people we support? Well, they're like every other resident of the district, and so it ended for them as well. And, you know, as I said last week, you know, we don't have any more authority to quarantine someone or tell them to stay at home. If we intend to impose any restriction on a person, there's a process that we need to go through before any restriction can be put in place. And so we just wanted to sort of walk through what those are. And we're drafting this, and I hope that this guidance will come out very soon. But if I'll just walk through some of the major points in it. First of all, you know, just that it is very important to remember that, you know, while the provider is required to put limits on when visitors come in, they have to agree to be, you know, they have to be screened. And if someone says, I don't want to be screened, it means they don't come in. And they may have particular, you know, the recommendations, the guidance from DC Health regarding visitation in supported living and residential habilitation was, to the extent there's a shared living space, because supported living, someone could live alone. To the extent there's shared living, if there's going to be a visit inside, there ideally would be, it would either occur in the person's room or there'd be an identified space. And the recommendation, I probably should have said this first, to the extent it can, it should occur outside. But keeping in mind that the people we support have the same rights as every other district resident. They have the right to go into the community. They have the right to have visitors in their home, outside their home. You know, providers can't issue a blanket ban on a person's rights. And however, if there are any proposed restrictions of the person's rights, then we do have policies and procedures in place. We have the DDS or the DDA human rights policies and procedures, which you can find on our website. And any restriction imposed on a person has to be individually justified, accompanied by a person's informed consent and reviewed by a provider's human rights committee with a right to appeal to the DDS Human Rights Advisory Committee before it's implemented. You know, I've said before, I really appreciate the steps that providers have gone to, the concern that providers have about ensuring the protection of all the people that we support. But the other thing is, keep in mind, phase 4, the point at which we really move forward when there will be a widely available effective vaccine or cure, will likely not be here for months and months. We cannot, well, first of all, you can't, without going through a process, you cannot expect that people's lives are going to be that restricted for a year to come. We have to start learning how to live in the current, you know, it's like, it's not that we're going to talk about what's the new day look like when this is over. What's the new day look like right now, and how do we begin to negotiate that? I also just want to quickly walk through some of the issues related to the community participation assessment and questionnaire. It's there to guide the team's discussion about restarting day and employment services. It is also subject to human rights policies. It is not required before a person can engage in other community activities. It's not required for people to have a visit or to go visit with people. It's not intended to be a directive to prevent people from engaging in activities based on their risk. It is intended to be a tool that identifies risks and plans for mitigating, for reducing those risks. Another really important point, and this is something that I'm hoping as we look at our, the PowerPoint we're developing and have our discussions, is really understanding the role of guardians, substitute decision makers, and people support teams. The support team doesn't vote on what a person gets to do. That's not their role. The support team is there to support a person in making decisions. Oftentimes, the support team is essential in understanding what it is the person wants, knowing the person, knowing what's important to that person and what's important for them, understanding what the person is communicating about what their wishes are, informing the person about their choices, and interpreting the person's responses to that to make sure that we are facilitating a person engaging in those activities that they want in a safe manner. So I think it will be really helpful as we draft this guidance and as we begin to have those conversations, because, like I say, none of this is new in terms of what the rules are that exist, but it is like it's very heightened. The implications of these decisions are very significant. So I'll stop talking, and I could be that now when I turn around, I'll see there are questions.
Okay, sorry about that, everyone. Who completes the CPAC for those in natural homes?
That would be the service coordinator working with the person and or family.
What about persons who would like to go on a weekend vacation and stay in a hotel? Does CDS have any guidance?
Out-of-town travel is discouraged. Our phase 2 guidance actually specifically says, hold on one second and I'll pull it up, does specifically address this. So if you'd go back and review the phase 2 guidance, I believe you'll see that it says, trying to find the exact language, but I can tell you that the answer during phase 2, the answer is no. In that out-of-town travel is still discouraged in phase 2. And I'm assuming that someone isn't wanting to go to a hotel in DC and spend the night. So a weekend away would be out-of-town travel, which is still, I'm trying to find the exact language, but it is still discouraged. Yeah, out-of-town travel is discouraged until stage 3 when it can resume.
Where do we find the CPAC to complete it?
It's in MCIS.
Profile. So if you go to MCIS and you go under person, it is approximately, it's under ISP information,
8 rows down.
8 rows down under ISP information. So MCIS, click on the person, then go to ISP information and scroll down 8 rows. CPAQ.
It would have helped if CPAC was created in the way LON was created. The way CPAC is created forces a person to complete all of it and committing it. It does not allow different people to complete separately the way the LON does. This can be abused.
I think the most important thing is the community participation assessment and questionnaire is then pulled up in a team meeting and it's discussed. And so all of the people at that meeting would then be able to weigh in on any concerns about risks that people have or have not identified.
Will providers be supported in creating policies to protect health and safety, requiring testing or quarantine for high risk or discouraged behaviors?
So there is guidance out already from DC Health regarding supported living and residential habilitation. I believe there's going to be guidance out from DC Health regarding testing. There will be guidance out from DC Health regarding ICF and regarding day programs. I'm very concerned about a question about a provider creating a policy that requires quarantine. Quarantine is something that's done by the public health authority in a state. So even people who had an exposure to a person with a confirmed case of COVID-19 are told to self-quarantine for 14 days. It would be helpful for that person to be tested, but that doesn't change the need for the person to self-quarantine for 14 days if there's been an actual exposure. For people who are ill, they should self-quarantine and isolate in their home. DC Health helps with making sure that that isolation is done correctly. all of those are the only measures in terms of quarantine that occur. Even where a health provider or DC Health advises a person to self-quarantine, they then check in to see how the person's doing with quarantining. I'm not aware, and I don't know if we have any DC Health people on the line, I am not aware in the district of any, so far during COVID-19, of any quarantine orders being issued to a person. To this date, what we've had is advice given to the person about what they need to do to protect their own health and the health of the community, and then there is follow-up to see how they're doing in complying with that advice or with following that advice. The public health authority steps in when someone is disregarding it, causing a real harm, potential harm, and then they would step in. So it gets me a little bit concerned when a provider asks about requiring quarantine for high-risk or discouraged behaviors. And these are the kinds of things that we will be talking about when we do in the PowerPoints that we're doing and when we have the discussions about how do we balance protection and rights during COVID-19.
A comment that was added was the health provider recommends the quarantine.
The health provider recommends that a person self-quarantine. When I got the flu 2 years ago, my doctor recommended quarantine. In fact, made me leave the office through another door to not be exposed to any other people in the office. Told me, go straight home, quarantine, stay at home for a week. You have to not have a fever for at least 2 days before you can be around people. And that would have been a form of self-quarantine. Quarantine, and maybe I'm being too legalistic here, quarantine is a legal word. So the doctor is telling you to stay at home. That is not an order of quarantine. We need to make sure that we're helping people to do what's best for themselves and to reduce the risk to others. But those are the same kinds of, for the whole country we see. Those are the kinds of discussions that happen in families and communities everywhere for all people. And it's really no different for us. And then when you think about in terms of, one analogy I have in terms of how this plays out in a particular placement, it's not really any different when you have shared living if one person smokes and another person has asthma. How do you manage that? How do you have discussions about where you're going to smoke? It's really the exact same thing. It's the same concept. And so we just need to make sure, how do we apply those concepts to our current circumstance? So we just have 2 minutes remaining. Today is a hard stop because I have a cabinet meeting I have to go to that begins right at 1 o'clock. So we use this new format because it really does help with the background noise, but I must say there's so little noise that I sometimes feel like I'm not sure there's someone on the other end. I do see the comments that have come in from people.
Okay. It appears that people providers are unclear as multiple people of authority are interchanging self-isolation, isolation versus quarantining, self-quarantining.
So this is the reason that we'll have this discussion, is so that people can be clear. Isolation is within the home. When you have a person who has tested positive, you need to make sure that they're isolated from everyone else. They're using, to the extent possible, a separate bathroom. They're staying in their room. They're eating their meals in their room. People are using all the appropriate PPE before they engage with them. A person who's been exposed, who has to self-quarantine at home, stays at home for the 2 weeks and monitors themselves for symptoms. I don't know that those people are told to isolate, but each of those would be things that isolation is a medical term, quarantine is a legal term. Self-quarantine has been used by doctors to say self-quarantine, which means you're telling yourself to quarantine. As I said, only the public health authority is the only one that can order you to quarantine. To date, they haven't really done that. But what we are referring to is when people are said, you really need to stay at home. And that is to quarantine yourself, to not go outside your home for the 2 weeks that you present a risk, potentially. And people should keep in mind that those 2 weeks, that's for people who have been exposed. I've heard people apply this 2-week thing once a person has been diagnosed with COVID-19. And the period of time that a person may be contagious with COVID-19 is an issue that should be discussed with your healthcare provider, because we have seen people with COVID-19 who remain positive for quite some time. So there, you really need to rely on the advice of the healthcare provider. I hope I'm making it clearer and not more confusing to people. Okay, I'm going to need to end the call now. I want to thank everyone who came. Just again, it's, as we have all this discussion about how we manage this, once again, just thank the providers and their direct care staff who are really on the front lines of helping us get through this. We've seen so much better outcomes. We want to continue to see those positive outcomes, but we also really need to learn together how people will live in this new normal. And the way it is now is the way it's going to be for quite some time to come, and we really need to learn together how to manage that so that people, all of us really, have the ability to do the things that are important to us while ensuring our own and other people's safety and health in the meantime. Thank you.